So in this case, I'll demonstrate how to remove an epiretinal membrane and subsequently the ILM. This is a diabetic patient with an epiretinal membrane. Epiretinal membrane should only be removed if there's drop of best-corrected visual acuity or metamorphopsia. With my initial stain, as you can see, the retina does not take the dye up equally, and there's area of botching, areas where there is staining and areas where the retina is not stained, and this is a clear indication that there is an epiretinal membrane or something in the way of the dye, such as posterior hyaloid or the membrane. So you begin by trying to create yourself an edge in the epiretinal membrane so that you can easily remove it safely. The trick is to pinch, slightly shake, release and repeat slowly but surely, and the aim of the shaking is to make sure that you're not grasping any of the underlying retina. Once you create the edge, as you can see here, you can safely start to use that edge to remove the epiretinal membrane. Try to always keep your vectors of forces, or the way you're pulling, not to pull away from the macula or from the fovea, but try to pull towards the fovea, just to prevent any damage or macular hole forming when you do these maneuvers. So once you're done with the epiretinal membrane, you restain with brilliant blue G, BBG, and as you will see clearly that now the retina has been stained homogeneously with the BBG. There's a small edge in the ILM membrane. I think this is an area where I attempted to, or I thought there was an epiretinal membrane, and instead I grasped the ILM. So I use or take advantage of this edge in the ILM in order for me to begin my ILM peel from. Again, the whole point is to grasp, slightly or gently shake. Make sure you're not grasping any of the underlying retina. Always try to pinch or hold the ILM from areas away from blood vessels to prevent any bleeding. Try to minimize the attempts of ILM pinching or holding as much as possible. Sometimes this is possible. Sometimes the ILM will come out in a single with a single grasp, like a rhexis in a phacoemulsification case. But sometimes it is thready, as you can see here, and tears. So you need to re-grasp and assess what's the direction or the right direction that you should pull in order to remove as much of the ILM as possible without having to hold again or attempt at holding the ILM again. So how far do you peel and why do you peel? You peel because when you peel, chances of the reformation of the epiretinal membrane is zero, as there is no scaffold for the cells, the glial cells, to reproliferate and cause a membrane. So this prevents reformation of the epiretinal membrane. And how far? Well, classic teaching is all the way up to the arcades. Sometimes you don't need to go that far. And as we all know, what we do is first do no harm. So you assess the situation, you assess your attempts at removing the ILM, and if everything is going smoothly, try to remove it all around the fovea itself, all the way to the papillomacular bundle, and you're done.